This is Jenna Kahn, Assistant Professor at Oregon Health and Science University. I'm just going to do an overview of GU cancers. We'll talk a little bit about prostate cancer, bladder cancer, testicular cancer, and kind of go over those different cancers and treatment options. So prostate cancer is the most common male cancer in the US other than skin cancer. Mortality is second only to lung cancer, and the prevalence likely increases with age. The median age is 66. There's over 200,000 cases a year and about 30,000 deaths expected this year. 1 in 7 men will get diagnosed with prostate cancer, and 1 in 30 men will die from prostate cancer. So here are some pictures of the prostate. You can see here we call the base of the prostate here is called the apex. This is the bladder, and then this is the urethra going through the middle of the prostate. And then above or connected to the prostate is the seminal vesicles. So in a different view, you can see here the bladder with the urethra going through the prostate and the different zones of the prostate. And then here you can see the rectum. You can see how close the prostate, bladder, and rectum are. So the peripheral zone of the prostate is 70% of that's volume, and it's the most common site for these cancers. The central zone includes the base of the prostate and encompasses the ejaculatory ducts and is about a quarter of the volume. And the transitional zone of the gland is usually what enlarges in older men, and it causes what's called benign prostatic hypertrophy and causes like a larger prostate gland as men get older. So prostate cancer screening, the ACS recommends initial screening at age 50, 40 if it's at high risk. So the way that we do prostate cancer screening is through PSA as well as digital rectal exam. The PSA is found in seminal vesicle fluid and plasma. It's produced by both benign and malignant cells and can have false positive and false negatives. Here you can see a picture of what a digital rectal exam is. Once your finger is inserted into the rectum, you press down and you can feel the prostate. Most people say the prostate is about the size of a walnut. So clinical presentation of prostate cancer, men can present with urinary symptoms that are similar to BPH or benign prostatic hypertrophy, such as frequency, weak urinary stream, difficulty starting or hesitancy, dysuria or pain with urination, hematuria or blood in the urine. They might have advanced disease, which can present with bladder outlet obstruction, urinary retention, ureteral obstruction, or not being able to urinate, or uremia. Metastatic presentation could be bone pain, anorexia, anemia. The workup for prostate cancer is, like we said before, the screening PSA, and if it's elevated, we do a DRE. You might be finding on your digital rectal exam nodules, induration, fixation, or enlargement. And about half of patients present with palpable nodules that might be malignant. Once a PSA is elevated, they see a urologist who likely would do a truss biopsy, which is a transrectal ultrasound guided biopsy. And that is a biopsy that is needed to differentiate between benign and malignant prostate disease, and can also give a good idea if there's maybe T3 or T4 disease, meaning extension outside of the prostate. Also gives us a good idea of the gland size. You can see here in a picture what a truss biopsy looks like. It's an ultrasound and a needle that goes through, and they take biopsies throughout the prostate. Here you can see a depiction of a prostate and how the prostate is broken up into sextants, and biopsies are taken from each of these different areas to make up your prostate biopsy. If the patient has high-risk disease, then we would add in other studies such as a bone scan, CT scan. Sometimes we order an MRI of the prostate, and sometimes we even order a specialized PET scan for prostate cancer. When we look under the microscope after that biopsy, we have pathologists who score the prostate cancer. And the scoring system is named after Donald Gleason from the Minneapolis VA, who developed it after studying 4,000 patients in the 1960s. It's based on the degree of glandular differentiation and the overall pattern of growth at low magnification. Tumors may display variable histologies, and 2 patterns are recorded for each disease. The primary is the first, it's the predominant pattern, and then there's a secondary or lesser pattern. And you can see here the Gleason pattern scale from 1 to 5 here, being well differentiated to more poorly differentiated. So as you go up in your Gleason score, it usually has a worse histology. In 2016, there was an update to the Gleason scores, and they were placed into groups, classifications. So grade group 1 is Gleason score 6 or less. Gleason group 2, Gleason group 3 plus 4 or 7. Gleason group 3, 4 plus 3 equals 7 as well, but the predominant is 4. Grade group 4 is 4 plus 4, 3 plus 5, or 5 plus 3, so any of them that equal 8. And again, whatever the first one is the predominant. And then grade group 5, Gleason scores 9 and 10. There are also these formulas in prostate cancer. You don't have to know these, but I just put them in here so then you understood that sometimes we put into we do a quick mathematical equation to see the risk of extracapsular extension or going outside of the prostate, or the risk of seminal vesicle invasion, also going outside the prostate and invading into the seminal vesicles we saw before. And then the risk of lymph nodes. The higher your Gleason is, the higher the risk of your lymph node involvement is. But we also want to take into account with all of these the PSA. So what are the patterns of spread for prostate cancer? There can be direct extension, such as the seminal vesicles, bladder, rectum, muscle, or bone in the area. It can involve the lymph nodes, such as the periprostatic lymph nodes, the obturators, or the external iliacs. And then distantly, I always say prostate cancer likes bone. Rarely liver and lung, but bone is one of the predominant spreads of prostate cancer. So what are the treatment options for prostate cancer? So generally, we would say surgery, radiation, plus or minus androgen deprivation therapy. And then there's also some chemotherapies that I'm not going to be going over today. We'll go more into the actual radiation therapy types of treatment. But generally, external beam radiation therapy, There is stereotactic body radiation therapy and brachytherapy. So prostatectomy, that is where you would take the prostate out. So you take the prostate and the seminal vesicle out, and also lymph nodes as well. And this can be done open or robotically. External beam radiation. There are different ways that we do this, but generally, the external beam radiation, the target is red. You can see the prostate right here, and we have a bunch of radiation beams that are coming in throughout, and they're treating the prostate, and we're trying to stay away from the rectum and the bladder. This is conventionally over anywhere from 5 weeks to 8 weeks, depending on the practice and depending on the dose fractionation for that patient. There is brachytherapy or internal radiation, and that is where needles are placed through the perineum into the prostate. This can be done either through low dose rate or some people like to call them seeds, where radioactive iodine seeds or palladium or cesium seeds get placed into the prostate gland. Those seeds stay in there forever, but they release radiation slowly over time and eventually don't have any more radiation after a certain amount of time. But they're treating the prostate gland alone from internal. There's also high dose rate brachytherapy where the needles are placed into the prostate, and you can see here this would be the source of radiation that goes in through each needle and comes out. So no radiation source stays in the patient while they're getting their treatment. So the way that we place prostate cancer patients into their treatment category is based on 3 things: their PSA, their Gleason score, and their T stage. We talked before about their TNM stage. So the T stage is that tumor stage. So for very low risk prostate cancer, generally Gleason 6, their PSA is low, less than 10. They have very less than 3 of the cores of their trus biopsy are positive, and no nodule is normally felt. And then that goes up per stage. So low risk is very similar to that, but you can have more than 3 biopsy cores positive. Intermediate risk is a PSA of 10 to 20, or Gleason 7, or T2, or you can feel a nodule. High risk prostate cancer would mean either the prostate cancer has gotten outside of the prostate gland, so extracapsular extension, or Gleason 8 through 10, or your PSA is greater than 20. And then very high risk, it's gone outside of the extracapsular extension, it's gone into the seminal vesicles or perhaps bladder or rectum, and the primary Gleason pattern is 5, or there's more than 4 cores with Gleason 8 through 10. So let's talk a little bit more about the treatment options per the risk groups. In low risk prostate cancer, the treatment options are active surveillance, radical prostatectomy, external beam radiation therapy, which would also include stereotactic body radiation therapy, which is a shortened course of higher doses per treatment to the prostate gland, or brachytherapy. Again, we talked about brachytherapy, is internal radiation, could be with those seed brachytherapy or the low dose rate radiation or high dose rate radiation. Active surveillance means no actual treatment. It's actively watching the patient. So a PSA and a digital rectal exam is done every 6 months to a year, and a biopsy every 1 to 2 years. And you might consider an MRI as well. Intermediate risk prostate cancer is broken up into favorable and unfavorable risk intermediate prostate cancer. And the treatment options again are radical prostatectomy, or you can have external beam radiation therapy, plus or minus. You might add an extra short dose of hormone treatment, which would be about 6 months. You could do external beam radiation with the internal brachytherapy, or you could do stereotactic body radiation therapy, that shortened high dose of external beam radiation therapy. And then there's high risk prostate cancer. That's treated with a prostatectomy and a lymph node dissection, or external beam radiation and hormones, which is ADT, or external beam and hormones and internal radiation therapy. So what's ADT? What's hormonal treatment? So the thalamus activates LH or releases LHRH from and the pituitary to release LH, and the testes to make testosterone, which then goes to the prostate cancer. Lupron is it's the androgen deprivation therapy, and it is an LHRH agonist that is the workhorse for hormone therapy, or ADT. You could get an orchiectomy, which means, no testes means not making any testosterone. And then another type of ADT is bicalutamide, which is an androgen deprivation blockade. And usually it's given maybe a week to 4 weeks prior to given the Lupron shot to prevent an initial flare seen with the LHRH agonist. But it's not always used. You can see here, the hypothalamus releasing the LHRH, and the pituitary releasing the luteinizing hormone, the LH agonist, blocking that. You can take out the testes, which would be surgical castration, and then the anti-androgens such as bicalutamide blocking the testosterone to the prostate cancer. I always tell patients giving ADT or androgen deprivation therapy is stopping the testosterone or the food to the prostate cancer. You're cutting off the food to it. If a patient was to undergo prostatectomy and has high risk features of local failure after prostatectomy, such as a positive surgical margin, then we talk about what's called adjuvant external beam radiation therapy to decrease the risk of a local failure to the prostate bed. And this is a curative treatment. We also are able to add or offer salvage radiation, meaning once the surgery has been done and the PSA is watched after surgery, the PSA can rise after a prostatectomy, and radiation can be given to cure or get rid of the prostate cancer, likely in the prostate bed. There's also been some new data and newer treatment options for patients with low metastatic burden. And we have been offering more radiation to those patients who have cancer that has gone to the lymph nodes or other areas. And when they have a low burden of metastatic prostate cancer, it has been shown to improve their survival in phase 2 data. When we talk about prostate cancer planning, initially it used to be 4 fields. So you can see here, these are the fields that are coming in. So it would be just given one in the front, one in the back, and one from each side. As we've had fancier treatment planning, we put in more beam options that decreases the dose to other areas, and we're able to form a more conformal dose distribution to our target and decreasing our dose to other structures that we don't want to give radiation to, such as the bladder and the rectum. You can see here, as we add more beams, we have more of a conformal dose of radiation, as opposed to having 5 fields. Some of the side effects of prostate cancer radiation include urinary frequency and urgency, straining to urinate, tiredness, loose stools or diarrhea, rectal urgency or possibly blood in the stool. Long-term side effects include erectile dysfunction, or temporary or permanent. They can continue to have urinary frequency or urgency, rectal urgency, and loose stools or diarrhea. Less likely rectal bleeding or blood in the urine or urethral strictures. But these are all side effects that are from radiation. So now that we've covered prostate cancer, we're going to move on to bladder cancer. There is an estimated 81,000 cases and 17,000 deaths in 2018. The median age for bladder cancer is 73. More males get this disease than females. And it's the 4th most common cancer in men, 9th most common cancer in women. Some of the risk factors are smoking, which is associated with 50% of bladder cancers in men and 30% in women. Might have other risk factors include polychromatic hydrocarbons, dye, paint, rubber, and leather industries, heavy metals, and a history of cyclophosphamide or chemotherapy or prior radiation. Other risk factors include chronic irritation, which is associated with a less common histology of squamous cell carcinoma. Schistosome hematobium is something you probably learned in your 1st and 2nd year of medical school, as well as having an indwelling catheter is another risk factor. These patients often present with painless, gross, and episodic hematuria. They might have irritative symptoms such as dysuria, frequency, or urgency. Might have urinary retention, ureteral obstruction with hydronephrosis, flank pain in really advanced cancers, but that's less likely. We work up these patients by doing a full history and physical. An office cystoscopy is with consideration of cytology. We do a CT scan or an MRI before the TURBT, which is called a transurethral resection of the bladder tumor. And we do imaging of the upper tract to rule out for synchronous tumors, such as a CT urogram or an IVP. We, as I said, do a TURBT plus or minus. Sometimes we do bladder mapping biopsies, and sometimes they even do a prostate biopsy if needed. Here you can see a scope going in to the bladder. Here is a picture of bladder. You can see the ureters coming in here. This is considered the trigone. This is the internal ureteral sphincter, and the external ureteral sphincter. And then you can see here the different layers of the bladder. So we have the lamina propria, the submucosa, the detrusor muscle, and the edge ventitia. And the growth as it goes through those different layers of the bladder tells us what stage the cancer is. So as you get more advanced, you go through more of the bladder. So if you're invading, the perivesicular tumor tissue, then you would be a T3. If you invade into another organ, such as the prostate, then you are a T4. So the general treatment scheme is that if you have a superficial tumor, then you do that TURBT plus or minus some chemo inside of the bladder, or BCG. And this accounts for 70% of all newly diagnosed bladder cancer cases. And the goal is to reduce recurrences and prevent the progression of the tumor. If the cancer is invasive, then we categorize them into inoperable or operable. If they're inoperable, then we talk about definitive chemoradiation. If the patient is operable, then we talk about plus or minus neoadjuvant chemotherapy or chemotherapy before surgery, and then radical surgery, or bladder sparing or bladder preservation chemoradiation, also known as trimodality therapy. In males, when you do the surgery, it's called a cystoprostatectomy, and in females, it's a cystectomy and a hysterectomy. So TURBT is a transurethral resection of the bladder tumor. It's for staging and for treatment. They try and do a maximally safe resection, and it should contain the bladder muscle wall and the perivesicular fat, as well as a bladder map to document the location, the number, size, and shape of any visible lesions. BCG is actually that Bacillus calmette-guerin. It's a live mycobacterium vaccine. It's that same vaccine that's used to prevent tuberculosis, and it's instilled into the bladder weekly for 6 weeks, and it generates an anti-tumor immune response that is used to augment TURBT. Cystectomy, as I said previously, in males, they take the bladder, prostate, seminal vesicles, the proximal vas deferens, and the proximal urethra. You can see that with this blue line. And in females, it's an anterior exenteration, so they take the bladder, the urethra, uterus, fallopian tubes, ovaries, and anterior vaginal wall. Urologists can do bladder reconstruction And the different types of surgery would be an ileal conduit, where you're incontinent and you have, a bag. So they bring a segment of the intestine to a stoma. There is also an Indiana pouch reservoir, which can have a little pouch right here, and then they also have a stoma, or have a neo bladder or urethra diversion, where they make a new bladder with your intestine and they connect it to the urethra. When we talk about bladder preservation, we kind of covered this already, but bladder preservation is the ideal candidates are primary T2 to T3 tumors that are in one area or unifocal, tumor size less than 5 centimeters in maximal diameter, not associated with extensive CIS, and no presence of ureteral obstruction or tumor-associated hydronephrosis. You want to have good capacity of the bladder, good bladder function, and visibly complete TURBT, as well as adequate renal function to allow for the chemotherapy given with the radiation. Bladder preservation treatment achieves a complete response and preserves the bladder in 70 to 80% of patients. There is long-term survival rates comparable to radical cystectomy. And quality of life studies have shown retained bladder functions do pretty well. Long-term toxicity of chemoradiation is low, and the incidence of cystectomy to palliate treatments of related toxicity, meaning your bladder not functioning as well and needing to get a cystectomy to palliate for that, is very low. The morbidity of a salvage cystectomy is comparable to primary cystectomy. So it's a good option for some of these patients. Here you can see a bladder, and you can see some treatment fields to treat this tumor here. And here you can see it well on the sagittal view and the coronal. Now we're going to talk about testicular cancer. And you can see and know that Lance Armstrong had testicular cancer. Testicular cancer is the most common malignancy in young men in the US. Most are actually germ cell tumors, either seminoma or non-seminomas, and the incidence is increasing. Patients present with small primary tumors. 50% of all patients present with stage 1 seminoma, and the most common age is between 18 to 35. As well as 30 to 34 for non-seminomas. They are 5 to 6 times more common in white men. Some of the risk factors include cryptorchidism, and those patients have 4 times higher rates of intra-abdominal testes, or 4 times higher in intra-abdominal testes than those in the inguinal canal. Other risk factors include Klinefelter syndrome, polyvinyl chloride exposure, family history, as well as prior testicular cancer. So 1 to 2% risk over 15 years in the contralateral testicle. Patients often present with painless swelling in the scrotum. 85% are stage 1. They have pain, heaviness, tenderness. They might say that they have a vague discomfort. Some patients present with back pain or abdominal swelling from the retroperitoneal nodes. Gynecomastia or beta HCG increase is uncommon. They might have acute pain from a hemorrhage, necrosis, or concomitant epididymitis. Another presentation might be infertility. Delay in diagnosis is often common. So the workup includes a complete history, including any previous inguinal or scrotal surgery, and as well as those risk factors. Physical exam, palpate the testes, and transillumination. You want to make sure you get a scrotal ultrasound of both testes and demonstrate a solid mass within the testis. You want to get a chest x-ray or chest imaging, as well as CT of the abdomen and pelvis. And then you want to get labs such as beta HCG, LDH, AFP, pre and post orchiectomy. These are the labs that can be elevated. In seminomas, AFP is not elevated if it's a pure seminoma. Beta HCG can be elevated in about 15%, and LDH correlates with bulk of tumor. The surgery is a radical inguinal orchiectomy with high ligation of the spermatocord. Scrotal violation shows that there's an increase in local recurrence with those surgeries. So just a general treatment overview. I'm not going to go too much into each treatment, but in stage 1, the primary treatment is surveillance, but you can offer adjuvant radiation or adjuvant chemotherapy. Stage 2A, adjuvant radiation or adjuvant chemotherapy. Stage 2B, adjuvant chemotherapy is preferred for those with lymph nodes greater than 3 centimeters, but could also consider adjuvant radiation. And then stage 2C and 3, chemotherapy. When we talk about radiation, some of the earlier stages, we would treat with just a periaortic field, which is what it looks like here. And then stage 2A and above, we consider a dog-leg field where we include the iliac and inguinal nodes. That's what this looks like here. That wraps up prostate cancer, bladder cancer, and testicular cancer. If you have any further questions, please feel free to email me. Thank you.